Well, welcome everyone, both in the room and online, to today's Think Global. This Think Global talk is part of our annual Global Cardiovascular Health Visiting Professorship, which is a joint endeavor between the Duke Global Health Institute and the Division of Cardiology. We are pleased today to have both an online and in-person session, and I'll let the introductions happen here in a moment. This Think Global is addressing a highly important but sometimes considered a neglected disease, rheumatic heart disease, and so we'll be digging into that today, both on all the way from prevention to really advanced treatment. This session today is going to be moderated by our own Dr. Rebecca Lumsden, who I'm going to turn over to here in a moment. Dr. Lumsden is an assistant professor at Duke University and also the director of clinical education at the Hubert Jurgen Center for Global Health. Becca did her undergraduate training at Emory and then medical school at University of Massachusetts, where we met during a Juris Duke International Clinical Research Fellowship, where she spent a year really studying rheumatic heart disease, and particularly how it's presented and how it's treated in women, and looking at perinatal outcomes and obstetric outcomes as well. So I'm going to turn it over to Becca to introduce the rest of our panel and enjoy the session.
Thanks, Jerry. Well, it's an honor to be here today. I have a very loud voice, so hopefully everybody online and in person can hear me. But before we start the session, want to give everybody a heads up that today's session will be videotaped and live streamed, to those and recorded, for those that are here in person and also watching virtually. So just keep that in mind, for question asking and whatnot. And we will allow time for Q&A. We have three amazing panelists today that are going to give us some short presentations and topic areas relevant to their own research and work. And then we'll open it up to questions and answers from the audience and have hopefully a very lively discussion. Rheumatic heart disease is a huge area of passion for me and much of the early driver of my sort of interest in women's health and cardiovascular disease. And I think it tugs on a lot of people's heartstrings from a humanitarian and a research and care delivery paradigm. So before we begin, I will introduce our panelists. To my left here is Dr. Andrea Beaton. She's a professor of pediatrics and pediatric cardiology at Cincinnati Children's Hospital. She is the founding member of the Rheumatic Heart Disease Research Collaborative in Uganda, where she spearheads initiatives to combat rheumatic heart disease on a global scale. Dr. Beaton holds leadership positions from the American Heart Association, the World Heart Federation, and the World Health Organization, where she serves as the co-chair of the Rheumatic Heart Disease Guideline Development Group. Next, our second presenter in our series is Lilian Mbau, who's virtual for us today. Lilian is a medical doctor, a public health practitioner, and a preventive cardiology specialist with over 15 years of experience in clinical care, strategic leadership, technical advisory, and policy development. She is currently a technical advisor for the Center for Cardiovascular Disease Prevention and Rehabilitation, CCPR, in Kenya, an organization that's dedicated towards shifting the focus towards prevention for cardiovascular disease by supporting the development and implementation of effective and scalable prevention programs in Kenya and the surrounding region. Dr. Mbau has worked both in public and private sectors and was recently the Chief Executive Officer of the Kenya Cardiac Society, where she led the development of its first strategic plan, setting the roadmap for delivery of excellence for cardiovascular care in the region. And our final presenter, also virtual today, is Dr. Jabaris Swain. Dr. Swain is a cardiothoracic surgeon, a global health scholar, and a physician business executive with expertise in cardiopulmonary transplantation and mechanical circulatory support. Dr. Swain has extensive experience in healthcare delivery and health systems building, particularly in the US and sub-Saharan Africa. So I'm going to turn it over to our wonderful panelists to hear from them directly, and then we'll open it up for some discussion. Dr. Reed, take it away.
Well, thank you. I'm really excited to be here with you guys today. Your campus is beautiful, and I've already enjoyed a wonderful morning with some of the faculty. So we'll be talking about rheumatic heart disease today, as Becca mentioned, which happens to be one of my favorite topics. So with that, I'm in charge of setting the scene today and then giving you a very brief overview of some of the work we do in our collaborative so that we can have a great discussion after. So rheumatic heart disease remains a disease of global disparity, and Becca alluded to this, but really anywhere that you find extreme poverty, fractured public health systems, and overcrowding of health systems and houses and schools, you're going to see rheumatic heart disease. It pops up again when these realities become true, even in areas that haven't had it. And currently, what you see is the yellow countries, which are endemic for rheumatic heart disease globally, essentially all of Africa, Southeast Asia, and across the Pacific, with more than 90% of the remaining global burden being in low and middle income countries. But as we're here in the US today, it's important to think about the fact that RHD is also a disease of local disparity. And while we don't have a lot of rheumatic heart disease here, it does affect our most vulnerable populations. So that map on the left is age-related RHD mortality for looking at disparities in outcomes. And so the red dots on that map are where the RHD mortality is highest in the US. And that tracks our southern states, across the western states that represent our Native American population, and in Alaska with our First Nations people. And if you look at this map compared to any other cardiovascular disease disparity in the US, it looks exactly identical. So we know our most vulnerable populations are affected. And also, if we think about our US territories like Puerto Rico and American Samoa, we have endemic levels of RHD remaining in those poorer island nations. So why is that disparity so stark, right? Why do we have almost no RHD in the US and other high-income countries, but it remains incredibly endemic globally? Well, what we see from the US data is that it's really economic development that catalyzed the end of RHD in the US. So 1940 there, where it says penicillin, wasn't the time. So that's what we do for RHD, right? We give people penicillin to prevent strep infections, and I'll get there in a minute. But the most important intervention ever developed for RHD came around 1940, 1945. That was World War II, where mass penicillin became available. But we see an enormous decline before that in the United States. And this is the same graph you get from Europe and other high-income countries, showing that as we improve living conditions, as we make things less crowded for people, we pass around less of the bacteria strep A that causes this disease, and you get enormous gains. But we can't wait on economic development to have the same impact globally, right? 80% of the world's children live in a place where it's highly likely they will be exposed to strep bacteria frequently and where RHD remains endemic. So all of that to say that's the global burden, right? Lots of RHD, 50 million people affected, 500,000 deaths globally from RHD. But what is rheumatic heart disease, which will become important when we talk about our efforts to try to combat this disease in low-income settings? Well, RHD strep starts as a simple bacterial infection. So these are the common strep sore throats that anybody who has children will know about, or anyone who has been a child, right? Strep throat's ubiquitous. Everybody gets it at some point in their life. But when you're exposed to strep frequently and you get common infections and they're not diagnosed and treated, some people will get an immune system overreaction. And that's a pretty limited condition called rheumatic fever. It goes away on its own. You get joint pain and rash and other nonspecific findings. The problem is it also silently damages the heart valves. And so about 2/3 of people who get a case of rheumatic fever will come out of the other side with early rheumatic heart disease. You can get really bad disease right away, but most people take this path for early valvular damage. And then next time you get a strep infection, which in these low-income countries may be 3 or 4 times a year based on our data, you're getting, again, an immune system overreaction that's damaging this heart valve. So that when people come to clinical presentation, they often have advanced stage valvular heart disease. And what we see is that in these early stages, strep A, rheumatic fever, early rheumatic heart disease, there's still a chance for children in those situations to return to health. But once you get to advanced stage rheumatic heart disease, it's really a chronically progressive disease with high mortality from heart failure, rhythm problems, infective endocarditis, and stroke that causes a huge burden of mortality globally. And in Uganda, where I work, if you come in with clinical symptoms as a kid, you've gotten symptoms bad enough where you know you have heart disease and you come into a clinic, about 1 in 4 of those kids will die within the first year of diagnosis, just reflecting the very late presentation of this disease globally. But because there's such an extended spectrum, there are lots of opportunities to intervene on this disease. So we can prevent strep A, so you never get rheumatic fever. Extremely challenging globally, but it does work. We've seen in small countries like Cuba, extremely effective primary prevention programs. We can find rheumatic fever, though I haven't highlighted it because it is so challenging to find rheumatic fever globally, and it's not a main area that we're targeting for interventions right now. And we can use echo screening. So this is where a lot of our work has come in. We can use echo, even single view echo, to find kids that have early rheumatic heart disease, which is an opportunity to start prophylaxis or giving them antibiotics so they don't get repeated strep infections. And even with echo screening, about 1/3 of people we find have advanced disease, but we can dramatically improve outcomes by knowing they have advanced disease and providing care for heart failure and pregnancy to make sure people remain safe. So what do I do in this space with that background? Well, I work at the Rheumatic Heart Disease Research Collaborative in Uganda, which Becca mentioned, but it's really a collaborative group. So this is the folks we've published with in the last 10 years. So they're really an all-comer. Anyone interested in RHD, we're happy to collaborate with you. But we work mostly on projects either in Uganda or informed by lessons in Uganda that are being translated to new environments. And our work is really organized in 3 main pillars, and I will go over these very superficially for this part of our talk today. But the first is that we've decided we have to implement what we know works now. So for a long time, RHD has been stalled by saying we don't have enough information on what we can do. But we're really focused on learning from what we've done in the past and implementing that, trying to get that out to as many people as we can now to impact the burden of disease. The second pillar has really been we have to innovate for the future. Most of what we know about this disease predates World War II. It was all done in America and US military recruits in the 40s and 50s, and a lot of that contemporary burden doesn't reflect that pattern. And so we have to innovate new strategies and use modern science to approach this disease. And then we just have to train the next generation. This is an incredibly small field. We all know each other. We all work together. It's wonderfully collaborative. But we always say at meetings, we need to not know more people who are here. It's very important that we have expand the workforce for research and clinical care in RHD if we're going to impact this disease globally. So in 3 quick examples, one way that we're implementing what we know, so this project is called Adunu, which means heart in the language of Northern Uganda. And this is an integrated program with the Ministry of Health. This is the first decentralized care program for RHD in sub-Saharan Africa. And we're partnering with the ministry to integrate RHD services into the primary healthcare system. So what we have now is we have active RHD case finding with nurse-led echo. This is a single view. We could teach everyone in this room to do it before we leave the session today. It's one view, it's easy to get. It's a yes, no, do you likely have rheumatic heart disease? And then we built capacity at a district level clinic to accept these referrals, to come up with a care treatment plan and to refer people back to their primary healthcare center using a mobile registry that we've developed that's been adopted throughout Uganda to make sure that we have the data on how these patients are doing and that we can track them and keep them in care. This program's been running with the ministry for 12 months now, so we are early days, but in one district, we've got 60 nurses trained at 11 facilities. They have screened over 17,000 community members. As part of their day-to-day activities, we found over 350 new cases of RHD, 2/3 of which are early enough to benefit only from prophylaxis. And we have high retention and adherence to that prophylactic care. So this model is scaling to another district later this year. And then we're hoping nationally and regionally as a way that we can take things we know now and get them to the population. The other thing we have to do is really innovate for the future. And I promise I'm not going to go over this whole slide, but this is the goal family of studies. We are dedicated to this acronym. But essentially, we are trying to establish the standard of care for children with early detection of RHD. So for about 10 years, even the work Becca and Jerry did, we know that anywhere we look in a low-income country, we can find 1 to 2% of kids living with this extremely early form of RHD. But screening hadn't moved into public policy because we didn't know, could we improve outcomes for these children? So that first study is the only one I'll talk about, but we did a randomized control trial where we screened about 150,000 children for rheumatic heart disease and got them linked into a clinical trial. And what we found is that it made a lot of logical sense, but prophylaxis could impact care even at that very early stage. And we found almost no children progressing if they were on prophylaxis, and about 10% of kids would progress to moderate, severe, advanced disease within 2 years. And this really changed the global picture of what do we do with these kids. And I'm always hesitant because it's one randomized control trial, but this has been adopted now into the World Heart Federation guidelines as recommended in public health spaces. And it's made its way into the new WHO guidelines, which should be coming out soon. So an exciting advancement to entice governments to act to find these children so that we can get them on prophylaxis. And finally, I think something that the Duke Global Health Institute believes deeply in is training this next generation. So we're very intentional in our work with Uganda to keep it an equitable partnership, but also to use reciprocal training, both of Ugandan trainees and US trainees, to build the capacity for global RHD interest and care. That's a D43 webinar series that we did with George Minsa, leading that first talk. He's the director of NHLBI's Implementation Science Division, and also the D43 in Uganda, which I know you guys have a lot of as well, training PhD and master's and non-degree people, getting more people involved in this fascinating and solvable disease. So my last slide is an African proverb that says, a hunter who hesitates to strike might only get the tail. I will not say it for you in language. Certainly someone could do better than me in this room. But we've been using this as the core of our mission to say, like, we cannot wait longer. We should not be waiting longer to act on RHD. We know enough to act now, even as we're innovating for the future. Thank you.
It was a wonderful way to set the stage and to sort of give us an overview and to hear about the really exciting things happening in Uganda, which are multifaceted. We're going to turn it over to Dr. Mbau now, who's going to tell us about what the state of RHD is like in Kenya, and fill us in a little bit about what she's been working on there.
Yeah, hi everyone. I hope you can see my slides.
Yeah.
Yeah, and hear me. Yeah, so thank you so much for this opportunity to present in this webinar. And I'm going to be just talking a bit about the status of rheumatic heart disease management in Kenya. And I'm a preventive cardiovascular medicine specialist, as you heard. And some of the what I'll be sharing is work. A part of it is work also the World Heart Federation has been doing, and I sit there in the advocacy committee, and also part of the work I did while I was at Kenya Cardiac Society as a CEO. So that's the outline of my presentation, just some background, some local data, care and prevention gaps, and what opportunities we have to improve RHD, rheumatic fever prevention and management. So I think just to emphasize this, I think most of us know that rheumatic fever is preventable. I think that's something we need to always keep at the back of our mind. And it has disabling long-term complications. Of course, we all know heart failure, atrial fibrillation, stroke, infective endocarditis, and also more importantly, pregnancy-related complications. And this disease disproportionately affects the young and economically active people in low and middle income countries. So I think also important to know that it's really affecting a young and productive population. And we also know that women are, we are getting now a big proportion of women in reproductive age bearing the burden of RHD, and this really affects some of the pregnancy outcomes. So just talk about Kenya. We don't really have nationally representative prevalence data, which is a big gap, because if you're trying to come up with national programs or even convince the government that we need to prioritize RHD, then it becomes a challenge. But we do have some data, and we have some data. One was done in a tertiary center, maternity center in a tertiary hospital in Kenya, where they found that RHD-associated cardiac lesions were found in 5 in 1,000 women. So you can see it is quite prevalent. And over 70% of newly diagnosed cardiovascular conditions in pregnancy were actually attributed to RHD. And also, it was found that maternal mortality was nearly 10 times higher among pregnant women who had RHD. So you can see that it is really affecting, and I'm happy to see Dr. Felix Baraza here. Is one of the people who have done quite a bit of research in this area. Hopefully he'll be commenting a bit later. This is some data that we did as part of Kenya Cardiac Society and the Ministry of Health. We tried to understand the burden of cardiovascular diseases, and we did collect a sample of about 11,000 patients. This was a retrospective analysis where we went through records of patients who visited 19 tertiary facilities between 2018 and 2020. And we found that rheumatic heart disease was the third most common cardiovascular disease there at 9%. And this is after heart failure and stroke. And just to mention that for heart failure, we did exclude those who had heart failure due to rheumatic heart disease. Yeah, and then this is another this is the same population of patients who I talked about in the 19 facilities. And I think what I wanted to highlight here is that out of the 1,028 patients who had RHD, 63% were female, which is the majority, and the average age was actually 29 years. So this is just to emphasize what I said, that this the condition is affecting a very productive population and is affecting more females, and this really translates to a number of women in reproductive age presenting in pregnancy with cardiac lesions, which definitely affect their outcomes. And the other thing I'd like us to note here is from this data is that the patients who actually got surgical intervention was reported at 16%. I know for the studies sort of estimate that about 50% of, at least 50% of RHD patients do require surgery. So this means that there is an issue with access to surgical facilities, and this is around cost and also just even availability of the surgical services. So this is just something that we need to take note of. This is data that, again, as part of Kenya Cardiac Society, we supported. And we established a heart registry, which was collecting data on 4 cardiac conditions, among which heart failure was one of them, in 3 tertiary referral hospitals in Kenya. And out of the 798 heart failure patients that we collected data on, you can see there that 13% of the heart failure was due to rheumatic heart disease. Again, the average age of these patients was 35. You can see they are quite a young population. Majority were females at 57%. And you can see the cost of admission. We also looked at the cost of admission for these patients, and you can see they have to part with at least $1,000 to get managed. And then the other thing is 18% of these patients were actually dead within 6 months. So we did 6-month follow-up of these patients post-admission, and 18% had succumbed. So you can see that this is really something that is bearing a huge burden to our population. And so I mentioned I am part of the advocacy committee at the World Heart Federation, and one of the things that the World Heart Federation has prioritized is rheumatic heart disease. And they came up with what they call a roadmap for reducing cardiovascular morbidity and mortality. through prevention and control of rheumatic heart disease. And basically, these roadmaps help identify the obstacles that are there and suggest possible solutions that could be applied to address some of those obstacles. And this is a continuum of care that was in the roadmap, and I want to use it to illustrate some of the gaps that currently we have. I know the print is quite small, but one of the biggest challenge we have, especially in Kenya, is community level awareness. So you can see there that there is a delay or sometimes lack of seeking treatment for patients who actually have the strep throat infection. So that's another, a big challenge that we have. And then even if they do come to the health facility, we do have the challenge of the health professional accurately diagnosing that throat infection as being a strep, infection vis-a-vis viral. So when we're doing a lot of trainings at the facility level, the health workers were struggling to really differentiate viral bacterial infection, strep. And another thing is even the diagnosis of acute rheumatic fever is itself a challenge. So a lot of capacity building is required there. And again, also we know the delays around even getting a diagnosis of rheumatic heart disease. Many of our facilities do not even have echo services. So again, delays at that level. Primary prophylaxis, basically treatment of the throat infection. The health workers, first of all, were not clear on which were the effective treatments for the throat infection. And even more importantly, how long. We know that the throat infection should actually be treated for 10 days. So a lot of health workers were treating either for 5 days or 7 days. And there was not enough education to the patient that they must take the medication for the full 10 days. So you can see there also a lot of gaps. And also when we come to secondary prophylaxis, the health workers did not know how long this should be taken. So that's one challenge. And secondly, we do not have registries, like well-structured registries to help us track these patients and ensure they do come back for their prophylaxis. So that's another challenge. I think I already mentioned the issue of getting treatment for RHD, even first getting a diagnosis, and then secondly, even getting surgical or specialist care is a challenge. So the same roadmap I mentioned has tried to summarize some of the interventions that would be useful for countries like ours. And I want to talk about the burden of disease data. We cannot underestimate this, because as we are trying to really show evidence of the burden, a lot of times lack of data becomes a big hindrance. Government engagement, this is very critical if you're trying to push this agenda. The issue of funding, I think we cannot underscore the fact that our governments need to allocate funding towards non-communicable diseases, including RHD, so that some of these conditions can be addressed. We do know we do have external funding, but it's not sustainable. At the end of the day, we do need our governments to actually put in to address RHD. Lack of lab services, I think I talked about that. Health worker training, another big gap that we have. Community education, I also mentioned, we don't have systematic programs to carry out community education, hence the delay in getting these sore throats diagnosed and treated. Guidelines. So I think for Kenya, we are quite privileged that we do have guidelines that we've had guidelines since 2018, and we recently revised them this year. So the only challenge is we have guidelines, but getting them out to the health workers is a challenge. As Kenya Cardiac Society, we have managed to disseminate these guidelines to only 9 out of 47 counties. So we do have a big gap in terms of getting guidelines out there, but at least the first step is we have the guidelines that have really clearly outlined how these conditions should be managed. Issue of primary prophylaxis, I think I talked about that. Issues around treatment of the sore throats. Vaccine development is another area that WHF is really trying to support to see how we can get that forward. issue of registries, a big problem in our country, and I talked about secondary prevention. So just to summarize the current gaps, we have lack of prioritization of NCDs and hence funding. I really think mobilizing local funding is really the only sustainable way of getting funds to manage some of these conditions. Of course, we also need to leverage on external resources if available. Lack of data, inadequate community awareness, access to diagnostic equipment, that's lab and echo, availability and dissemination of clinical guidelines, training of health providers, establishment of national registries, and RHD management in women of reproductive age, that's also is a gap. So in summary, I think very important, we need to have clinical guidelines, we need to train our health workers, we need to do awareness creation, we need to build diagnostic capacity, availability of medication, research and vaccine development, and have data and registries. But at the bottom, I really emphasize that prioritization of RHD and funding allocation at national level is really critical, and also multi-sectoral collaboration. So thank you, and then looking forward to discussion.
Thank you, Lillian. I think that very much, reiterates that this is a health system-wide, disease scope, that starts from basic case identification through sort of treatment into the utmost subspecialized surgical intervention. So thank you for alerting us, to what the state of things is like in Kenya. Lastly, we're going to hear from Dr. Swain, who's going to tell us a little bit about the surgical approach to this and what it really looks like on the tail end of the most advanced disease and how we treat it, and his experience in Rwanda.
Terrific. Good afternoon, everyone, and thank you for the privilege of the podium, or rather the screen. Really nice presentations from the previous speakers, because I think they did a great job at setting the stage for my ability to offer a perspective from the surgical context. Again, I'm Jabbar Swain. I'm faculty at the University of Pennsylvania, but also the Director of Innovation at Johnson & Johnson MedTech. But my connection with rheumatic heart disease dates back to about maybe 14 years ago when I was a general surgery resident at the Brigham. And it was in that capacity that I had the opportunity to be mentored by the late Dr. Paul Farmer and Atul Gawande, as well as others connected with an organization called Team Heart. And for the next few minutes, I'd like to share a bit of the perspective, or primarily the experience of Team Heart, a 501c3 that has been entrenched in the efforts of rheumatic heart disease, not only from the perspective of surgery, but also providing sustainability. And I'd like to also highlight some of the challenges that have been faced and what we believe to be the way forward. And so I won't spend a lot of time on the introductory slides, but I just want to highlight here that this slide was developed circa 2005 or so. And it was at that time that there was an estimate of 23.6 million people would die from cardiovascular disease in 2030. And this is old data, and our new data suggests that the number will be larger, and we're waiting for that to come out. But I want to highlight just the fact that cardiovascular disease continues to confer a pretty significant burden. And then when we think about low and middle income countries, rheumatic heart disease and congenital heart disease continue to lead the way. And it was several years ago that Dr. Farmer was one to say, surgical colleagues, you need to be involved. When I was first introduced to rheumatic heart disease, the question always was around, well, surgery is expensive, and is there really value in providing surgery to these kids with this advanced disease? But I think, as Dr. Beaton pointed out, there's only so much we can do with primary and secondary prevention. But there are a population, and particularly young adults, adolescents, and kids who end up with that advanced disease. And, the question then becomes one of ethics. Do you do nothing? Do you spend resources or allocate funds that may not necessarily be available in country to support an expensive operation? or do you rely on humanitarian efforts to try to bring forward, some sort of intervention? And so that in mind, Dr. Farmer called on the surgical colleagues to speak fluently about rebuilding infrastructure, training personnel, and delivering high quality care to the very poorest. And with that, he was asking us not only to, come over with our scalpels and provide an intervention, but also think really or be very thoughtful about how we can create a sustainable opportunity. And so this theme continued even in some of our professional societies in surgery as some of the senior leadership felt that it was important for us to begin to enter the discourse around rheumatic heart disease and not only bring our talents to these under-resourced areas, but also our expertise in helping to build infrastructure. And this kind of ideology or ethos is memorialized in a number of different doctrines or edicts that have been, come together to articulate the role that surgery could play in rheumatic heart disease and how resources could be amassed from a variety of different sources in order to support what is thought to be an expensive endeavor. And so when we talk about surgery, particularly in Rwanda, Uganda, or any of the other countries similar to those places, a lot of times people think it's something like this. But unfortunately, if we want to expect the same or better outcomes as we can command in first world countries, we have to bring forward those resources. And so surgery no longer looks like what we see here, and neither it also doesn't look like kind of the traditional kind of go out and do hernia repairs. There's so many moving parts. And so even to think about providing surgery to under-resourced areas, there needs to be an interdisciplinary and a multidisciplinary approach in order to be able to not only execute surgery in a meaningful way, but also to support the patients after surgery. And so that's sort of kind of where the idea around surgical mission trips came into mind, where people would come in and they would provide surgical care, but there was an obligation beyond just providing the care. Because what would happen is they would come in, do the surgeries, and leave, and then you would leave the country with patients that struggle to manage their INR, folks that had postoperative wound infections, and there was no one trained in the country in order to manage that. And so this is sort of kind of like what surgical engagement when it comes to rheumatic heart disease began to look like. There were outreach programs, then different groups across the country, particularly in the US, would develop team trips. There are programs like the Human Resources for Health program, organized by the Clinton Healthcare Access Initiative Group, where visiting scholars and educators from the US would come into places like Uganda or Rwanda and partner with providers and kind of do a skill transfer to help them to support those patients. Then there's global network systems. We have some well-known like Charitable Hearts across the world where you would refer patients for surgery. Again, academic faculty and curricula have been developed over time that are focused and targeting, not only prevention efforts, but also surgical efforts. And then, what came about shortly after my surgical training, where I did my general surgery in Boston at the Brigham, there's now a new appetite of general surgery residents who are interested in being trained and providing care in resource-limited settings. And there are some programs now that offer global health equity residencies in surgery to prepare residents to become leaders in that space. But bringing it down to Team Heart, this organization kind of saw it from all sides. It started out as a mission-led organization, but then, as I mentioned, really moved along the continuum of providing more sustainable long-term care. And so for over a decade, Team Heart has performed cardiac surgeries in Rwanda. And the focus has been on severe heart valve diseases, particularly rheumatic heart disease. And over 100 surgeries have been completed there. I'll go over a little bit of the outcomes just to share what that experience has looked like. But the primary focus has been on valve replacements, which them in itself require ongoing anticoagulation management, which I'll highlight shortly as well. But in order for these surgeries to be successful, Team Heart had to and continues to work in partnership with the Rwandan hospitals, healthcare workers, and more importantly, the Rwanda Ministry of Health and the government in order to ensure sustainability. And so really quickly, the patient journey, I think, is critical to consider here. And, that journey includes not only diagnosing rheumatic heart disease with the echo screening programs across the country, but also long-term management. Initial diagnosis of most patients present in a lot of cases either in the mid or late stages because oftentimes the stories that we would see would be young kids that would be playing soccer. Then one day, particularly in Rwanda with the rolling hills, they have developed shortness of breath and unable to continue playing, and then they be admitted to the hospital and with advanced heart failure. And when you put the probe and do the one, the single axis view, you see, a hugely open MR or AR and demonstrating that there's a rheumatic valve there that needs to be replaced. And so, and I highlight rheumatic valve that needs to be replaced because some will say, well, what about repair? But oftentimes these kids come at such late stage that the valves are almost completely disintegrated such that there's no tissue there available for replacement. And that's going to, or excuse me, repair, which is critically important to understand why anticoagulation challenges are present in these areas, because those patients tend to require mechanical valve implantation. And so Team Heart has taken on the responsibility alongside other organizations, but primarily Team Heart has done complex surgeries like valve replacements. And, they've also taken on the responsibility of carrying the leadership in guiding postoperative recovery with anticoagulation therapy. Now, with our, typical evaluation of our patients, we do similarly to what we have here in the States. The patients are identified with echo screening. We do a full history and physical, and their heart failure is usually classified. All the routine tests are done. The exception that is not usually done in the US is the malaria smear because it is endemic to that area. We then do chest x-ray and echocardiogram to confirm the disease and decide what type of pathology that we're going to be dealing with. And then there are two options that, the decision tree undergoes: bioprosthetic and mechanical valves. Bioprosthetic valves are usually bovine or porcine, which are tissue valves. And so those have a really short half-life. When you think about the life expectancy of a young person, their longevity is about 10 years or less. And then after about that time, the patient will need to require another operation. And so there's also an increased risk of endocarditis. And, the patient that we typically would consider for the tissue valve would be women. And those would be women who are interested in procreating or having kids, particularly in the setting of the main stage of anticoagulation in Rwanda is Coumadin. And we understand that Coumadin is teratogenic. And so if a woman is unable to take Coumadin and wants to have kids, there has to be a strategy in place in order to support them through the surgical and the postoperative period. Mechanical valves are usually the fail-safe because they'll last a pretty long time, but they require lifelong anticoagulation. And this creates a challenge because it's not only the responsibility of the patient and the health system to, make sure that the INRs are managed and the patient takes the medication, but the country also has to have a supply of the medication, which often is a challenge. And there have been cases where we've had to provide the country, 14 million people, with the supply of Coumadin. And so, there comes a question of ethics when you go into a country and you implant mechanical valves, but then don't afford or enable opportunities for the medications to manage those valves to be in place. And so, but that said, even with the layering of the problem that exists there, there are success stories and many of them. I'll tell you one of a 19-year-old male who was diagnosed with rheumatic heart disease. He underwent a valve replacement by Team Heart in 2019. He was placed on warfarin therapy, requiring consistent INR monitoring to maintain therapeutic levels. And after 6 months of follow-up, the patient showed stable INR levels and excellent recovery with support of Team Heart and health workers. And this is a really quick kind of illustration of that patient's background, 32 kilograms. Now, if you think the average human is supposed to be around 70 kilograms or more, and so a 19-year-old being half that weight So really small, and it's evident in, from the failure to thrive. With functional class 4, had some mitral valve malcoaptation, which means the leaflets in the mitral valve were not closing properly, which allowed for significant MR mitral regurgitation, elevated pulmonary pressures with moderate severe RVE and severe rheumatic disease. And also this patient had disease affecting the tricuspid valve. And so not only are there multi-valve, not only are there, this patient had mitral valve, but also tricuspid, which makes the operation that they would require much more complicated because it's a multi-valve replacement. And on top of that, the patient has atrial fibrillation. So it's likely a derivative of the cardiomegaly that established from the disease valves and the requisite MR and TR that was present. Real quickly, I'll show just these stills of the echoes, and you can see those who are, you don't have to be, echocardiographer or imaging cardiologist to see that this blue means bad, particularly when it's on this side of the valve. And so that's a significant MR and TR that needs to be addressed, or otherwise that patient will meet early demise. And then even on imaging, we see the chest X-rays are pretty significant. The image here on the right is a normal chest X-ray of a 19-year-old. And then this one on my left, your right, possibly kind of backwards, but the imaging here in the middle here has a huge heart, and that's the typical cardiomegaly sign of a patient who is suffering from MR and TR and requires surgical intervention from that advanced disease. And these are the valves that were explanted, the mitral valve and the tricuspid valve. And as you see here, like it's almost a complete whole, like there's really no coaptation there. And so the question is always asked, how do these patients actually even survive with this level of pathology? And there's no way that you could utilize some sort of suture repair to try to, give these patients a repair. So they absolutely have to have a replacement. Unfortunately, and that again makes the operation that they require much more challenging. And so this is sort of kind of one of our intraoperative images. I think this is Dr. Amy Fiedler and Maurice Masani doing an operation. Dr. Fiedler is a cardiac surgeon at UCSF who I worked alongside in Rwanda for several years since we were both residents. And then Dr. Musani is a cardiac surgeon who Team Heart supported to get his training to become a cardiothoracic surgeon. And he's actually the first cardiothoracic surgeon in Rwanda. And these are some of the patients that have successfully recovered from surgery and gone on to have really strong and been able to thrive well. And so real quickly, some of the surgical outcomes, about 366 patients were captured from a registry that was maintained from 2006 to 2023. And those are all patients who received cardiac surgery. Mostly were young with an average age of around 25 years with the preponderance for female patients. Mitral valve surgery was the most common, either alone or single valve at 45.9%, with tricuspid valve 20%. There's a very low 30-day mortality at 1.9, but long-term, there has been a multi-cause mortality of about 18.2%. And a lot of that has been secondary to things, not having adequate, post-surgical follow-up, infection, valve challenges and anticoagulation. And much of that mortality rate was driven by the early experience, which has now come down to the single digit with the most recent years after having learned how to better support these patients. Bioprosthetic valves, the few that have been implanted have a higher mortality, and mainly because those valves begin to fail and the patients will require a secondary operation. And unfortunately, in a place where the under-resourced area, having a second operation is likely not possible. And then mechanical valve patients, some of the challenges they face include embolism or bleeding complications, while bioprosthetic valves, again, the biggest issue with them is deterioration or even infection with infective endocarditis, because there is tissue that is in those bovine and porcine valves. But moving forward, there are still, with those challenges, patients do well with replacement in these settings, but it is important that they have appropriate postoperative follow-up, particularly in the area of anticoagulation. And Team Heart has thankfully been able to support anticoagulation therapy and proper follow-up through their nurse training program throughout Rwanda. And much of that success has been from collaborations with health providers, as well as with the local government. In order to ensure continued long-term success, we understand that, anticoagulation is critical for these patients after valve replacement, and that they need to have access to INR testing and the medication. And so anyone who takes on the responsibility of providing surgical care will also need to think through how they're going to be able to participate in the postoperative management of these patients. And then, patient adherence is still a challenge, just as it is here in the US. Socioeconomic factors, including cost and travel, hinder adherence to therapy. And it's probably a greater hindrance because oftentimes these patients live far out in remote areas and encounter challenges getting to the district hospitals or to the main hospitals in Kigali. And then, going beyond just the patient factors, training local healthcare providers. It was only within the last decade that Rwanda saw cardiac surgery in the country. And so being able to actually, recognize those patients, understand and anticipate the challenges that they would encounter, and being trained, on echocardiography and other modalities to be able to quickly diagnose, triage, and get those patients the care they need. Education not only had to go or be placed with the providers, but also with the healthcare system. And then, the healthcare infrastructure of Rwanda needed to be sure fit to create a safety net for those patients, such that if something happened, there was a clear direction of where the patients need to go in order to receive proper care. Because as we understand, any delay in diagnosis and treatment after valve replacement can mean early demise. I'll kind of stop. This last slide just reiterates some of the challenges, and the recommendations for moving forward. First we need to, again, the surgery part actually for us is, the easy part. Cardiac surgery in Rwanda is the same as cardiac surgery at the Brigham or at Penn, or at Duke even. It's the same conduct of operation, although it can present its challenges in regards to the pathology that presents itself. But, the actual replacement of the valve is essentially the same. But there are challenges regarding the support of those patients. And so we understand that there's an imperative around increasing access to diagnostic tools. More INR testing machines and monitoring sources are needed, especially in rural areas. We need to expand training for healthcare workers. A broader and continuous training on anticoagulation therapy management should be prioritized. And that's not only for providers, but also for nurses and community health workers. And then strengthen follow-up care systems, building more robust patient follow-up protocols to ensure long-term adherence to anticoagulation therapy is going to be essential. I'm going to wrap up here, but I wanted to share this, example of sustainability in a very unique way. This is Ernest Simpunga. Ernest was a patient who we identified more than a decade ago in Rwanda with very severe rheumatic heart disease, such that he was not, the resources were not in place in Rwanda to have his surgery completed. So we actually flew him to Boston, to the Brigham. And this is Dr. James Ron auscultating him. And so Ernest had valvular replacement done at the Brigham. Was able to be successfully recovered and came back to Rwanda to finish high school, where he graduated, went to college, where he graduated, and now he is a medical resident with the expectation that he's going to go into cardiology. And so it's a full circle of how, just that one intervention can change the entire trajectory of, the life of an individual. And so when there's the blanket statement of, oh, surgery's too expensive, we should not invest. I always go back to Ernest as an example of how, we can continue to just invest even in one life, how it can change the trajectory of an entire generation. And then lastly, I'll just share these two final examples. This is Maurice. He was a general surgery resident when I first met him over a decade ago, and he would come and visit with us during our Team Heart missions and help us manage our patients. Maurice finished general surgery training in Rwanda and then was supported through cardiothoracic surgery fellowship at the University of Witwatersrand in South Africa, and has since returned to Rwanda to lead the first cardiovascular program there, where Team Heart and other partners continue to support him to provide cardiac surgical care. And the next stage is to begin to create training programs there in Rwanda for cardiothoracic surgeons. And then this is Georges Gasana. He's also a general surgery resident who texted me 2 days ago to let me know that he just completed general surgery training and will be starting his cardiovascular surgery fellowship at Tenwit Hospital in Kenya. And again, these are true examples of how, just the thoughtful investment, not only financial, but also the thoughtful investment from a health system strategy and building perspective that can help create lifelong and long-term opportunities to support patients who suffer from this disease. I'll stop here and thank you again for the opportunity to share this experience.
There's also a great New York Times article from 2018, actually, about Team Heart in Rwanda and rheumatic heart disease. I think we maybe have time for maybe one question from the audience, and I'm sure much conversation, at least on this side, can happen, and we'll share contacts too in case people want to reach out. So maybe we'll take two. There was, since we have the boss, and then we also had one very, very eager question from the audience. So you want to start, Dr. Breyer?
Yeah, so Andrea, you had alluded to the autoimmune component of this disease, and it's so striking that there's this gender disparity that all the speakers have spoken to. And, we do see higher rates of autoimmunity and autoimmune pathogenesis in women. Do you think that is a part of what is happening here?
Click on right. Yeah. No, that's
Yes,
true.
I am.
So I think there's likely two components that have been theorized, at least on the 2/3 women, 1/3 men. If you look at rheumatic fever, which is largely 5 to 15-year-olds, so largely before puberty, you see equal amounts of rheumatic fever in most places. It's people who go on to develop rheumatic heart disease, those immune-mediated complications that end up being 2/3 women almost everywhere you look, and that
Right.
mirrors lupus and other autoimmune diseases and the preponderance of women to have those diseases later in life. We also think there could be an environmental component to that because kids drive this disease.
Right.
Kids have superficial strep A infections, and women in most locations where RHD is endemic are primarily the child caregivers and the teachers and the people who are interacting with those strep containing children. So it's
Right.
probably a combination, but it's likely autoimmunity and the pattern that we see in post-pubertal women that drives that.
Yeah, recurrence.
Yes.
Thank you for the great presentation. My name is Afnan, and actually I'm like building up on that. So I'll take us back to prevention, speaking to how there are people who are more susceptible than others. And I've seen there have been like studies to assess like genetic predisposition in a lot of places in the world, but I've only seen that in Asia in terms of Africa. So I wanted to know if there are other studies. Also in terms of like people living in the same house, families can have more of the predisposition due to environmental causes and genetic causes. I've seen there's also a study in Uganda that uses echoes and to know like to detect like early detection among like a family of a patient who has it. So I wanted to know if you know about other studies doing that and how has it been like in terms of the echo-based studies?
Okay, that's a lot of questions. Okay, but I got it. Okay, yes, there are more genetic studies. So there's 3 big studies out now. One's RHD Gen, which was a African collaborative led by the late Bongani Mayosi. That data is out. Mark Engel, I think, may be one of the senior authors of that now. I can send it to you. The other is from the Pacific. And Tom Parks, who's at Imperial College in London, is putting all these together right now in a meta-analysis for a global genetics background. There is clearly a genetic component. If we look at twin studies from the 50s, we know that identical twins have more rheumatic fever together than non-identical twins. But we also know that it is largely environment that is driving this disease. So clear by the map. Some people will never get rheumatic fever and rheumatic heart disease, no matter how much you expose them. But environment is driving this forward. So genetics have a huge important role right now because it's an insight into pathogenesis, which we still don't totally understand. And in some of the work we're doing on finding new rheumatic fever biomarkers, we are seeing signals in the rheumatic fever cases using modern proteomics and RNA-seq data and autoantibody data that reflect what they're finding in the genetics on how our immune system overreacts. But genetics is never going to be our answer, obviously, globally. It's how do we address this and prevent it in the environment? Your other question on echo screening, zillions of studies now. There have been echo screening across 6 continents. Again, in this period where we said echo was a research tool to figure out how much RHD there was out there. And I can send you some of those studies. Just shoot me a.
Well, thank you, everyone. I want to take a second to say thank you to all of our speakers for shedding light on this often thought to be neglected chronic disease at this point, and really highlighting the entire sort of utility of the health system and health system strengthening, both sort of as technology case detection becomes really important, all the way through sort of our surgical management of a very unique disease. So thank you to everybody, and feel free to stay around for some more question and answers in the room.